Welcome, everyone. My name is Tanya, and I'll be moderating today's conversation session around harm reduction health and the program that we're running in CHEN. This hour is designed to give you a clear sense of what this program is, how it was developed, and how the lived and clinical expertise behind it directly shapes the learning experience. We have assembled an amazing panel for you. They are our instructors as well as our program advisory committee members. So you're going to hear from people working like you on the front line. And to start us off, we've had a couple of people join us. What I'm going to do is we're going to do what's called a chat waterfall. And we're going to find out who has joined us today. So I'm going to put a question for all of our guests in the chat line. And if you want to open that up right now, and if you can tell us a little bit about yourself, your name, if you'd like to share your name, you don't have to, your professional role, where you're joining us from, especially if you're outside of the province of Ontario. We'd love to know if you're joining us from another part of Canada, whether you're currently working in harm reduction health or in a related area, and if there is a topic or a question you hope will be addressed today. I'm going to give you a minute to do that, to type something in. Give people just a little more time. Tell us about themselves. If you missed what's in the chat right now, and you've just joined us, please introduce yourself by your name. Tell us your name if you'd like. You don't have to. Your professional role, where you're coming from, city or province, whether you're currently working in harm reduction health or a related area, and one question also that you'd like us to address today. So we've got Nancy, of course, wound care specialist from London. Hi, Nancy. Nancy does teach for us in CHEN, and we've known her for many years. Yes, and she's had the pleasure of working with Jordan when dealing with harm reduction and education outreach workers and professionals in that setting. And Jordan is one of our instructors and PAC members. Hi, Nancy. Okay. Well, everyone, please feel free to just, if you're still typing, I'm just going to keep us moving along, but please let us know who you are. Oh, hi, Vicki, a nurse from St. Elizabeth Health Foundation. We operate a homeless hospice as part of our foundation work, and I'm involved in developing the TIC content for clinicians and non-clinicians as part of our Center for Equity and Innovation in EOL Care. Welcome. Thanks for joining us. I mean, this is right in your space. You've joined us for today. Okay, I'm going to keep us moving, but please, people, everyone, please do add in who you are and share. I am going to do our land acknowledgement, and this is specific to where I am, but you're welcome to share your own. I acknowledge and give thanks to the land on which I live and work, and to the Indigenous peoples who have cared for it. This land is the traditional territory of the Anishinaabeg, Haudenosaunee, and Huron-Wendat, and the Métis peoples, and it is covered by Treaty 13 and the Williams Treaties. I also recognize the presence and stewardship of the Chippewas of Georgina Island First Nation, and I am committed to learning, listening, and supporting reconciliation in meaningful ways. Okay. So we're going to start off by telling you a little bit about the program. And let me just bring up my handy slides here. Oops. Can everyone see my screen?
Yeah, it's perfect.
Great, great, thank you. Okay, so we're going to tell you a little bit today how we're going to run this is we're going to tell the story behind the program, just familiarize you with where it's come from. I'm going to give you a brief program overview, and then you're going to meet our instructor panel, and I'm going to be asking them a series of questions that will give you some insight into where the program has come from, who they are, and what we feel is the meaning of this program in the larger community providing this care. We're going to give you a chance to offer some questions up for to be answered, and then we'll close out. And doesn't mean you can't ask some questions, like put questions in the chat line as we're going through the discussion. As your questions come up in your head, please add them because Rosemary Kaur, Dr. Kaur, who is head of CHEN, she's going to be helping me monitor that chat line. So for this program, um, let's start off a little bit about CHEN. We are the Canadian Healthcare Education Network. We have over 15 years of experience in post-licensure education. We were formerly at York University's Health Leadership and Learning Network. That's where I'm from. I was its former director. Uh, we we focus in on long-term care, wound care, navigation, and communication, um, and broadly clinical skills in many other areas of healthcare. And our programs are designed by and for frontline healthcare professionals. So this is a quote recently located by Dr. Kaur, Rosemary, and it really spoke to us and said it all. No one can deny that there is a homelessness problem, that there may be more open drug use in the city. This was referring to a city in the Maritimes. There may be more petty crime, but if public safety means more police and policing, that's not going to solve the problem. And that's not because the police are not good at their job. It's just that they're not trained to solve homelessness or addiction or mental illness. And this is a quote from Dr. Michael Boudreau, who's a criminologist. He's not in healthcare and chair in the Department of Criminology at St. Thomas University. So it's a little eye-opening for us to see someone outside of healthcare commenting and agreeing with us. So I'm going to talk a bit more about the program, but let me give you some background. So this program did not start in isolation at all. It came from somewhere, it grew out of something. It was developed through a collaborative process. We worked with a program advisory committee made up of experts from across Canada, including the community and frontline providers of care, which are on our panel today. We especially engaged with the Chatham-Kent harm reduction health groups, of which we have an instructor here with us today, and drew on key learning from a symposium last year with Mish, who's talking today, and another PAC member who's not here today, that helps shape some of the core thinking behind this course. And this grounding is so deeply valuable. It ensures the program reflects real world practice and not just theory. This is not an academic program. This is practical and applied real world application based program. I'm going to put a link and for you to listen to after. I'm going to put a link to a symposium that we ran last year, of which Mish was heavily involved in its creation. Sorry about that. I just unmuted for a reason. I'm going to put it in the chat line, and you're welcome to review it at a later date. But this is our symposium from last year that really was the groundwork for starting this. Okay, let's go over the program. So I've got in front of you information about our harm reduction health program, certificate program. And it's focused on health professionals, outreach workers, community organizations, frontline teams, leaders that support this complex care environment. The program focuses around evidence-informed harm reduction practice, trauma-informed person-centered care, communication and engagement skills, yes, sort of help supports rounding out the program, and ensuring the sustainability of your practice, responding to substance use in healthcare and community settings, and building confidence in complex real world situations. And we've learned ourselves, Rosemary and I, for many years of being in this space, that confidence is such an important part of the overall competency. Why this program? Healthcare professionals, they're increasingly working with people who are experiencing substance use. It's just the way it is. Housing instability, trauma, mental health challenges, and barriers to care, often without formal preparation or support. The elephant in the room is, it's important to talk about this. Why is harm reduction so politically charged? And it is. Unfortunately, it is. But as educators, we want to step beyond that. Harm reduction has become more than a healthcare issue. It's now, unfortunately, deeply political. And these public concerns about homelessness, open substance use, safety, and community impact have intensified the debate. The term itself can trigger strong reactions, misconceptions, and polarization. So frontline health professionals are caught between evidence-informed practice, organizational expectations, public opinion, and political decisions. Yet the reality remains the same that healthcare and community professionals continue to care for people affected by substance use. It's what they are doing and they have to do. Trauma, mental health challenges, poverty, and housing instability every day. So this program is intended to create space for evidence-informed discussion, practical skills, compassionate care, that critical thinking, the real-world application well beyond politics and rhetoric, a space where this education can advocate for provision of safe care that is evidence-based. We want to focus on learning that connects to practice, which we always do in CHEN, and that is why we've developed it through a collaboration. Our education always focuses on real world scenarios and applied learning. We are practical and applied, interprofessional perspectives, everything you would see in a standard requirement for best practice learning, postgraduate, professional learning. Participants will explore stigma and bias in care, safer substance use approaches, motivational interviewing and communication, which we feel is quite novel in an education program around this space, system navigation and advocacy, again, something quite novel in education around this space, and relationship-centered care. The outcomes and what participants will gain, which I think everyone who's looking at a new program will want to know, what will I take away? You'll have that knowledge base, which we're going to contribute to, adding to your knowledge in that foundations of harm reduction health practice. We're going to, the course or the program provides skills in everything from therapeutic communication, that relationship and trust building, navigating difficult conversations, and practical harm reduction approaches, and building that confidence, which we do in all of our courses. It's a theme that runs through all of our programs, supporting people, using that part of that competency of confidence to support people with dignity and respect, working more effectively across the system. You are an advocate. You have a voice, and applying harm reduction principles in everyday practice, not just in the space where you're practicing directly with people who need your care, but also with fellow healthcare professionals and people who may be developing policy or supporting system change. So you really are a clinical leader when you emerge from this program. Our goal is to strengthen the ability of healthcare and community professionals to provide that safer, compassionate, and more effective care, and also to support everything from policy development and system change. We've made it as flexible as possible. This is an applied active adult learning process. And these are the modules that are in the program, which you can see on the website. And our faculty, which are here today, Whitney McMillan, Jordan Lindsay, Mish Varaksa, and Lee Kaplan. And we're going to hear from them now. Here's the QR code for, which I'll flash up on the screen later in the session. This QR code leads right to the program page on our website. And you're free to use your cameras and go there right now. But right now, I'm going to now move it over to our panel session. Okay. So a welcome to all of our panel members. And I'd like to now invite all of our panel members to tell us about themselves and answer some questions for you. But first, let's do a little bit of an introduction from each one. So for each panel member, I'd like to invite each of you to introduce yourselves and share your professional background and experience. And I'm going to start in no order. And I start off with Whitney, if you can unmute yourself.
Hello, everyone. So I'm Whitney McMillan. I'm a health advocate and patient navigator located way over on the West Coast in Metro Vancouver, BC. As well, I'm also the program director and senior instructor with CHEN's patient navigation program. My career background is in social work related healthcare, primarily, with many roles supporting people impacted by key social determinants of health. In particular, I possess a strong trauma-informed harm reduction approach based on my work experience with chronic conditions, domestic and intimate partner violence, and emergency management. Currently, I'm on a mobile response team that's deployed to provide psychosocial support during natural disasters, wildfires, floods, things like that, as well as, unfortunately, mass casualty events. Our priority when we're in the field is supporting frontline workers such as firefighters, police officers, paramedics, healthcare staff, and community workers. Our approach is that by supporting the mental well-being of frontliners, we ensure they are best able to support the broader community. During our responses, we are continually assessing for harm indicators. When faced with harsh realities like evacuation from your home, the fear of literally losing your community, or sadly, when humans harm each other, stressors rise to levels that can implode in a person. When a person is also living with addiction, mental health issues, and/or challenging family dynamics, these are really heavily compounded. So our team takes steps to help mitigate the added burden via harm reduction strategies.
Thanks, Whitney. Really appreciate that. Thank you. And next one to introduce themselves, Mish.
Hey there, my name is Mish Waraksa. I'm a nurse practitioner and I've been an NP for the last 8 years. I'm located in Toronto, Ontario. Previous to being an NP, I worked in high-risk obstetrics in the hospital. And as an NP, I worked in primary care for a few years before I moved into working initially in harm reduction. So for 4 years, I was, excuse me, working in a safer supply program as the clinical lead here in Toronto. And if you're not familiar with safer supply, they're programs that are harm reduction programs that provide prescription opioids for folks to reduce their risk of overdose and other complications from exposure to the toxic fentanyl supply. And after that work, I worked in a harm reduction-based hepatitis C treatment program, community-based Hep C treatment. And for the last year, I've worked as a substance use consultation NP at North York General Hospital. So in this role, I see folks both in the emergency room and people admitted to hospital, whether that's something directly related to their substance use, such as alcohol withdrawal, or people who are admitted for another reason but require supports for substance use, the supports that need to be addressed to help them remain in the hospital. So I'll treat people's withdrawal, also provide them harm reduction education, initiate treatment for substance use disorders, and also make plans and connections for people to have community supports after discharge. So I'm very interested in the intersection between harm reduction and healthcare and how those things sometimes don't perfectly align together within our systems and how we can have transformative change within the system for people who use drugs.
Great. Thanks, Mish. Thank you for telling everybody about yourself. And next is Jordan.
Hello, bonjour everyone. My name is Jordan Lindsay. I use she, her pronouns, and I am really privileged to be the Community Drug Strategy Coordinator with the Chatham-Kent, Ontario Health Team. Chatham-Kent is a small, fairly rural community of communities in southwestern Ontario, part of Treaty 2. And we are a fairly conservative community, and we tend to be fairly behind when it comes to substance use policy and health equity work. So we do have a lot of challenges locally, but we learn so much from partners across Ontario and across Canada. And prior to my role as the Community Drug Strategy Coordinator, I had about 10 years of experience working in substance use in different capacities as a public health nurse for our local public health unit. And I had the absolute privilege and opportunity during that time to be part of a local initiative where we noticed that we were making decisions and designing programs and services for people who use substances, and folks experiencing housing insecurity and income insecurity without involving the people that were most affected by these issues. And so a group of local partners came together. Our local outreach organization, Reach Out Chatham Kent, really drove the work, and we started engaging and asking folks with lived and living expertise to join us for meetings. We were able to get a couple of grants to compensate folks for their time and expertise, and really from the ground up created what we now call our peer-to-peer program. And now all of our work within the Chatham-Kent Ontario Health Team, Community Drug Strategy, our public health unit, and many of our partners across the substance use continuum of care take a nothing about us without us approach and engage folks with lived and living expertise in co-designing those solutions. So I'm continually humbled and amazed, and really take leadership from people who are living it and whose knowledge and expertise just spans far beyond mine ever will. So I hope that I can offer that lens through these sessions. Thanks, everyone.
Thank you. Oh, thanks, Jordan. And thanks for giving us a glimpse again into your space. And Lee Kaplan. Oh, Lee, can you unmute yourself? Or
Yes, I can.
There you go. That's great. Okay.
Hi, everybody. I'm Lee Kaplan. I am, as you saw, a diabetes nurse educator. Been in there for over 30 years and see a lot of use of communication skills. So I've actually done a lot of extra training. I'm a health and wellness coach, and I actually teach health and wellness coaching to people. I also am Mint trained in motivational interviewing by the Mint network of trainers. And my thought on harm reduction is I've done some street health in my past as a birth control counselor at the Bay Center for Birth Control. So did some street education around gynae care, which did a lot, and communication was something that was quite important. So it's been something that's taken me through how do I actually improve people's health through communication. And harm reduction, I've actually been diving into that a little bit in the sense of I don't want to ignite anybody in their harm. So been looking at communication in the sense of how do I keep people safe and be able to listen to them more effectively. So those have been important pieces that I've added and been, I call it rabbit holes. I tend to go down different rabbit holes. And one of them is communication and how I can make it better for people. And in the sense of addiction and helping them to improve their lives. So thank you.
Thanks. Thank you, Lee. Thanks for giving us an insight into your space as well. So now I'm going to go into some questions with our panel. And to panel members, I know I give you 10 minutes, but I'm going to give you 5 because I realize the time, and we still want to have time for Q&A. So let's start with Whitney. And so I must say, this is the new space that we're going into in the certificate program, because Whitney will be teaching the courses on culture and diversity in a binary world, and she's also touching on patient navigation. So, Whitney, you work across healthcare systems and patient navigation spaces, and you have extensive experience supporting individuals experiencing these complex health and social challenges. What gaps do you see between the care people need and the care they often are able to access? Because they're two different things. How can professionals better navigate
Yes.
those gaps while maintaining dignity, trust, and person-centered care, and respecting and supporting culture and diversity?
Okay. So I'm probably going to answer this in some layers, which is really what diversity is about, is layers. So and possibly the reason I'm going first is also because the course goes first. And the course, the Culture and Diversity in a Binary World, forms the foundation for the rest of the harm reduction program, as it sets the stage for culturally safe harm reduction care. So you'll hear me use that phrase a lot. Throughout the course, we really ground our professional approaches in who we each are as a person first. So we take a person-centered approach, starting with ourselves. And certainly during the course, we unpack layers of diversity, including cultural background, but so many more layers of who we each are. So age, sex, gender identity, sexual orientation, generational histories, economics, geography, relationships, family dynamic, all of these things, personalities, values, etc. It's in those layers that our personal culture grows, because yes, we each have our own personal culture, which breeds our personal values, our worldview, our opinions, our attitudes, and our actions. So our personal culture is how we see the world, express ourselves, and interact with others. As frontline professionals, how we show up in service to others really matters deeply, deeply. So how much of ourselves do we bring? How could we be getting in our own way of helping people? How could our own values and perspectives impact others, even when we're not meaning to do so? So the Culture and Diversity in a Binary World really is a course that is a really, really precious opportunity to self-reflect deeply on yourself. It's a gift of time and focus to do a facilitated process in order to enhance your self-awareness, to better prepare you to engage in frontline work with vulnerable people. It aims to enhance your greater understanding of your own personal cultural lens, so you can engage people with greater empathy, compassion, and respect for their own personal culture too. And why is cultural safety important to harm reduction? Well, in the blending of healthcare and harm reduction, cultural safety is based on respectful engagement that recognizes and strives to address power imbalances, historic trauma, and systemic discrimination. It ensures that care environments are as free as possible of discrimination in all of its forms. This way, all individuals, particularly marginalized groups, feel safe and supported when they're accessing healthcare and social services. So cultural safety, harm reduction matters because stigma and fear of discrimination are primary reasons that people avoid seeking life-saving care. When harm reduction services are culturally safe, it validates the dignity of the individual. It significantly improves the health equity, and as a result, the overall well-being of a person. Cultural safety is about addressing systemic discrimination and power imbalances. But it's also important to keep in mind that true cultural safety is always defined by the person receiving care, which shifts the power dynamic away from the institutions and the systems toward individuals who define what makes an environment free of biased judgments and discrimination. In the course, we look at the individual micro level. So that's where providing culturally safe care involves the health care or frontline worker being able to practice cultural humility and self-reflection. We also look at the team and the organizational meso level. And this is where care is strongly influenced by the values and culture of the workplace and the care environment. which might feel like beyond our control sometimes, but it is an important piece. Taking on a strengths-based approach is extremely important around creating a inherent community of inherently on community and individual strengths, cultural resiliency, as well as a trauma-informed lens. And with that, culturally safe harm reduction is built on mutual trust, dignity, and compassion, while avoiding re-traumatizing people through judgments and potentially coercive behaviors. So integrating culturally safe care prevents patients and clients from avoiding essential care out of fear for discrimination. By treating individuals with dignity and respecting historical as well as social contexts, we actually promote health equity, we foster healing, and we reduce the risks associated with substance use. I will touch on just briefly one of the key pieces, just one of the key pieces is I used a term, and I want to make sure it sort of lands with everyone, is cultural humility. We often talk about cultural competence, and that's this sort of this sense of knowing. And really, the only person that can know something is someone living the experience from their lived reality, someone with the background, someone who lives and knows it, but other people do not. And so our course is really focused on a sense of cultural humility, which is not about knowing, but it's about wanting to better understand. And so it's really about being respectfully curious. And with that sense of humility, cultural safety requires that a person reflects on their own biases, acknowledges the past histories of other people, and provides a setting or environment where individuals feel respected and secure. So that really is about engaging in our ongoing self-reflection about our own personal biases, because we all have them, and humbly acknowledging that we are learners. That's a key piece.
Thank you.
Because if we can do that, then we can value other people that we're serving in terms of their own autonomy.
Mm-hmm, mm-hmm. And just to let everyone know, I mean, Whitney's been teaching this course, and it was Rosemary was also teaching it. And people come into this course and think, I know how to do this, but you'd be surprised how many of us, generally, even amongst practitioners, really haven't done it, haven't done that self-reflection piece to really understand their own understanding of their own maybe personal approach and biases. So that's why this program, that course is part of this program. So thank you, Whitney, for that, for opening it up. And you're absolutely right. It is the first course for a very good reason. You can hear why. Sort of sets the stage then for the rest of the learning and gives it a good foundation. Next is Mish. And this is when the rubber starts to hit the road in the program. We really get into that clinical space. So Mish, you are working like directly with people who in substance use consultation for safer supply and that acute care. What are some of the realities that frontline healthcare professionals may not fully appreciate until they're really working with people who are using substances? And what knowledge or perspective do you believe every clinician should have?
Yeah, I think one fact I often bring forward when I'm doing presentations or training of new staff is highlighting that discharge from hospital is actually one of the highest risk periods for overdose. And I always think about this as, people are coming into contact with healthcare and as a result are actually leaving with a higher risk of death. Um, and how much that really highlights what a problem we have with our competency in this area of care and providing good care to people who use drugs. Substance use care is unfortunately not really prioritized in our training, even though we're experiencing a drug toxicity crisis that actually killed more people during the COVID pandemic than COVID itself. And yet it hasn't been a political priority or a healthcare priority. So this is why this course is so important to learn more, to provide better care, and it really can be truly transformative in our healthcare system if we can improve the quality of care that people are getting. It's been mentioned, but I think people need to realize just how widespread the discrimination is against people who use drugs in our healthcare system, and really the huge burden of stigma and fear that people experience when they're in contact with healthcare. Working in the community, I often had folks who were having acute medical issues, even people who had symptoms of a stroke or symptoms of a heart attack or a severe infection, who were very, very reluctant to attend the emergency room because they had past experiences of poor treatment or past experiences of being left in really bad withdrawal, and they knew that they'd be in agony with their unmet needs or unmet pain needs. And unfortunately, I really couldn't tell them otherwise. I couldn't sort of convince them that that wasn't going to be the case when they went to the hospital, because it's unfortunately is the reality for many people. So just highlighting what a big need we have for this kind of education as healthcare workers. I want folks to also know that this is really rewarding work. It's really such a vibrant community to work with, and there's so much to learn from people who use drugs. Through the decades, when there's been an inadequate response to the toxic drug crisis, to overdoses, the community of people who use drugs have really come together to develop and share knowledge and strategies that help take care of themselves, to take care of their friends and family and their community. So we're often almost looking at this issue with a lot of almost pity. But again, going back to that strength-based view and seeing that there's such a wealth of knowledge within this community that we can help support if we can learn from people who use drugs. And it's such a great area of work because there's so much allyship between patients and providers that's possible. I've been involved in research projects with people that are clients of my programs. I've been on panels with patients. It's a really interesting space to work in. I think people also need to know that we have a drug toxicity crisis and not just an overdose crisis. And it's not simply that there are more people using drugs or using opioids, for example. It's that the actual drug supply itself has become more toxic and it's changed over time. And as providers, we really need to have knowledge about the adulterants in the supply, because it changes the clinical presentations that we see. It changes the kind of interventions that people need and the kind of also the social supports that people require, and what life really looks like for people. It's important because it's just desperately needed for people to be able to provide better care to this community. And I really look forward to working with folks that are interested.
Mish, thank you. And I can't, I have nothing to add because that was so beautifully put and succinctly stated. But you can see, everyone, that this is really at the heart of the program itself, and getting this knowledge out there, and creating more of an approach that is as a standard in education. We always say we're creating a standard. So everybody is speaking the same language and is drawing from similar knowledge and expertise and a similar competency in terms of the way they approach things. And that is why Mish is teaching in this program with her depth of expertise and knowledge. So with that said, it's a good now dovetail into introducing Jordan Lindsay and what Jordan will be teaching. And Jordan, your work is now, so we're taking it from that clinical space, that direct, like face-to-face clinical space, and we're taking it out to that broader community space and how everyone is working together. So Jordan, your work brings together like public health, community partnerships, and local drug strategy, which you really have such depth of expertise in. Why is harm reduction health no longer just the responsibility of specialized teams? What role do you see for community organizations, municipalities, and frontline professionals in creating safer systems of care?
Thanks for that question, Tanya. I think it's so timely and so important. And from that place of cultural safety and that strengths-based approach that Mish talked about, that's always the question that I'm asking is, how can we support community members, loved ones, service providers, decision makers, and leaders to see themselves reflected in this work, because substance use, although I think many of us get an immediate picture or image of what that looks like, because that's how we've been conditioned to view substance use. And as you talked about, sort of that visceral reaction to even the language and the word harm reduction that comes up for some of us. But the fact is that most people in Canada, most Canadians do use substances, like anywhere from 70 to 90% of Canadians use substances at some point in the last year, with alcohol and cannabis actually being the most commonly consumed, right? And data also suggests that anywhere from 1 in 5 could meet the criteria for a substance use disorder in their lifetime. From what we have learned locally in our community, some of our survey data actually suggests it might be around 1 in 3. And so harm reduction is really an approach, but it's also a set of principles, it's practical strategies and practices, and it transcends substance use care. It can be used across disciplines, settings, and care environments, and with different populations really across the lifespan. And it's not just the responsibility of harm reduction workers or specialized substance use teams, not even just healthcare, because the risks and harms that we are concerned about, so toxicities, the toxic unregulated supply, stigma, social concerns, these are system-wide issues, and they intersect with housing, with healthcare, with the justice system, with community safety. So we really need co-developed and co-delivered solutions that are implemented across systems and are not done in isolation. So we often call it like a no wrong door approach, that anywhere someone goes, they should be able to access the care and support they need, or at least be pointed in the right direction. And the reason that we need more harm reduction or more substance use care across specialized or traditional settings is the scope of the drug toxicity and the drug policy. I don't even like to use the word crisis, but I think that's the language most people recognize. It's just continued to grow, right? Like as Mish said, there are more deaths related to the drug toxicity crisis than from COVID. And it affects people in all different spaces and settings. And harm reduction workers can't be everywhere all the time. And there's really not that many of them. Like we don't get a whole lot of funding. And we know that the highest risk moments actually occur outside of these traditional services. So immediately after release from custody, after hospital discharge, like Mish said, during housing instability or those transition periods, and when people use alone. So across Canada, most fatal toxicities actually occur in private dwellings. 1 in 4 people in Ontario who died from opioid toxicity during COVID had an interaction with the healthcare system in the week prior to their death. 1 in 10 occurred during the first year someone was released from jail. 20% of those were in the first week after release. So tragic, but also opportunities for us to do better. And harm reduction is not just about programs and services, it's about systems, policies, the culture, right? And from a systems theory perspective, if we're thinking about what are those root causes, what is contributing and driving these issues that we are seeing, it's not individual choices. A huge driving force is stigma and failed drug policies, right? And we've all been shaped by misinformation and harmful rhetoric about substance use, and we all carry stigma. So I think we need to acknowledge that what we have been told and taught is not an accurate or fair picture of substance use. It ignores that diversity of experience and the cultural role of substances, that there often can be a strength-based and a really like an adaptation and a coping mechanism there going on. The root causes of harm are really incredibly diverse, and at the baseline that people just deserve care and support. And the result is that we've got this culture of fear and shame where people are punished and excluded instead of supported across many different spaces, right? And if punishment and exclusion worked, people facing poverty, houselessness, incarceration should, in theory, have the best recovery outcomes. But research shows the complete opposite. People succeed when they have resources, support, and hope, right? And I think that's what harm reduction seeks to do.
Jordan, thank you. That was in a nutshell, so succinct. And can you see, everyone, that there is a thread of leadership, what we call clinical leadership, running through this program. So you're at the front line. You're also at thinking at a level of what influences better outcomes. And through the certificate, we hope that you can act as a leader within your own space, within the system, to support policy development, change, what is within your scope. And that also is a good segue into what Lee Kaplan will be covering in the space of communication, because communication skills are really essential in having those more difficult conversations and exerting influence with people who can make change, but also with providing the best care you can in a compassionate and supportive way. So Lee, much of your work focuses on communication. You have that depth of expertise in communication, motivational interviewing, and supporting people through really difficult conversations, whether at the bedside, working directly with clients, or working with people who can influence change in the system. So my question to you, Lee, is many professionals tell us that they know what they should say, and they're uncertain about how to say it. They want to say something, but they're not quite sure how to position it. Why are communication skills so fundamental to effective harm reduction health? And what difference can they make in outcomes for both clients and the providers themselves?
Thanks, Tanya. I think I like the positioning of this because I sort of come in at the end and sort of how do we all put everything together, from cultural humility, which improved communication can help. Talking about safer supply and where it goes can help people feel that it's a safe place to talk and tell you their concerns and their ambivalence about making changes. And definitely that other piece of it's everybody's job. So it's treating somebody, and I like the idea of treating everybody as if they're a human being. So the idea around communication is to improve that. I think sometimes we haven't practiced those new words, and I always do this, is like getting those words out and learning how to do that. I think that that's a big piece of it. So in the sense of part of this is to practice the skills, is that sometimes the words are different and we worry about, are we going to harm this person more? So how do we say it and learn how to say it and practice it in a safe environment so that we can bring that out? I think communication is fundamental anytime. And I feel that it's known to help build rapport, build the trust for someone to feel that they can actually tell you the true story, because people come with what they think we want to hear. And then as we start to make it more person-centered, and that we have that growth mindset, that the strength is within that person to make this change, and to help them build that strength to do that. And that's where communication can help people move forward. And I think that those are learning tips and tricks. And it's not tricks, it's learning new skills to actually help people feel safe to actually tell you the true story that's behind what brings them there, and that they haven't had success, but they showed up again. So it's like taking that strength of you actually came back to an appointment. And I think that those little pieces and steps and crumbs can actually help people move forward in their communication. It can help decrease that stigma, that shame that people come, that they actually feel that they can tell their true story, improving that safe environment. So I think that all of those pieces we can help just through our communication and how we go about doing it. And I would say to you, most of us come skilled in communication, and that's what I hear is, but I know this stuff. It's not a bad thing to actually revisit it and learn a little bit more. And I think everyone would come at a different level to learn these skills, and then they walk away with a little bit more. So I always say, what are you doing well? And how in the future can you make it even better yet when you meet this client? And I even use that with the people that I see who struggle with addiction, who struggle with in all facets of their lives. You know, what are they doing well? Because a lot of people are doing a lot well. And those are the strengths that we can build on to make it the next time they approach something to make it even better yet. And I think communication is the place that can just bring everything together and help build empathy, like Whitney talked about, and build that growth mindset instead of that everyone's coming at a deficit, that people actually have strengths and they're human beings, and by treating them as so, we can actually improve, and we will have a better dialogue. So I think in some ways it's for the clients, but in some ways it's job satisfaction. It's like, oh my gosh, I'm actually having better quality conversations with my clients because I'm person-centered, and I'm treating this person as a human being. Looking forward to this. I'm very excited.
Thank you, Lee. Thank you, Lee. And you're right, it is at the end on purpose. And we put our communication always at the end of the program because it sort of ties everything together, because you are having discussions at the heart of it. Now we are almost at time. I'm wary of the time. And I wanted to open it up to questions from people who've joined us today. I don't see any active questions in the chat, but so I'm going to ask a question. Oh, here's Rosemary's asking one. Building on the criminologist's opening statement, do you believe Police Services and Correctional Service Canada would benefit from participating in a cultural safety and harm reduction focused program? If so, what meaningful changes would you expect to see in practice or organizational culture? Who on the panel would like to address that question? Just unmute.
I can take just a first stab, and then team if you want to add.
Okay.
I do, right? I do believe that anyone working within the criminal justice system would really benefit from harm reduction, cultural safety training. It's actually a recommendation in our community drug strategy, and I know that it is in some broader plans within that system as well. I think that often, because there are such limited services, our first responders that work 24/7 around the clock are coming across individuals through the night, during hours where services are not open, and are unfortunately faced with having to try and navigate through health and social issues. And I don't think that is the basis of a lot of their training, although I think that there has been some changes to adapt and try and include more of that in recent years. So often they are the first point of contact. We also know that people who use substances, Black and Brown folks, First Nations, Inuit, Métis, and urban Indigenous communities are disproportionately represented within our criminal justice systems due to the legacies of colonization, due to systemic racism, due to systemic stigma associated with substance use, right? And so I think there is a lot that needs to be unlearned and undone as well, but that perhaps by having these kinds of conversations in more open ways and doing more learning, connection and support with folks with lived and living expertise and incorporating those voices are one small piece of that really complex puzzle that needs to happen. So would very much support engaging those folks in these conversations.
Jordan, thank you. Thank you. Because it does go beyond healthcare. Absolutely. So we're almost at time, and I'm mindful of time and people getting back to their day. So we have a closing question that I was going to ask the whole panel, but I'm actually just going to ask one panel member to volunteer to answer it. The question is, if there is one reason someone should invest in developing their knowledge and skills in harm reduction health today, going beyond what they already know, adding on this new knowledge, what would it be? And I'm going to pose it to Mish because you're really sitting there on the front line. What would you say to people about if there's one reason someone should invest in developing their knowledge and skills in harm reduction health today? What would it be? What would you say to them?
I would say because we need to start looking at this as fundamental competencies as providers. I think often substance use health is sort of looked at as specialized or sort of optional. We have a lot of providers that will just refer elsewhere or sort of say that's not within my scope. And really the standard of care is that we're providing the opportunity for treatment if that's where someone's at with their substance use, that we're offering harm reduction at every contact, that it's available at first contact with every person. And yeah, because I think it's fundamental, and we need to be able to provide this care to people, and it's so impactful on people's quality of life, and on the outcomes that we see on honestly preventable deaths when it comes down to it.
Mish, thank you. And thank you. And I know we all completely agree around an established standard of care. Everybody's speaking the same language approach. So we're at the end of time. We've got 1 minute, so I'm going to bring up on the screen the certificate, a little bit more information, and to contact us here in CHEN if you have additional questions. info@chennetwork.ca is how to reach us. And I'm going to just pull it back to the QR code just in case anyone wants to take another screenshot, because that'll take you right to the program website. We welcome questions, thoughts, comments. If you're in the harm reduction health space, tell us what you think as well. We are always looking, it's an iterative process, developing education. We're always looking to improve what we're doing. If you'd like to be part of what we're putting together, we have a program advisory committee. Reach out to us. Perhaps you should be a member too. I want to thank our really experienced and committed panel of instructors and PAC members who have joined us today. We can't do this without you, with your advocacy as well, and not just your extensive knowledge and expertise and where you are in the system. So thank you for helping us put this all together and for being here today to talk to everyone. So this will be available as a video for everyone who's listening in. And it'll be posted on our YouTube channel, and I'll be sending that out to everyone who has registered for this session today, as well as our general CHEN community and broader. So please share this video widely with everyone that you know in the harm reduction health space, nationally, even internationally. please let them know about this program, and we look forward to seeing you in our program in the future. Thanks, everyone. Take care now.